When a massive burn trauma hits, the clock literally starts ticking instantly. So let's jump right into this explainer and completely demystify the intense, highly systematic protocols that medical responders use to save lives in those absolutely critical first 24 hours of severe burn management. The complexity of care required in these early hours is just staggering. And the Advanced Burn Life Support, or ABLS protocol, that is the definitive, life-saving roadmap healthcare providers follow when everything is on the line.
Here is the exact roadmap we're going to use to understand these critical protocols today. We'll start with the global burn epidemic, move into the primary survey with the ABCDEs, look at the secondary survey and history, talk about sizing up the burn, dig into the actual math of survival, and finally cover when to transfer.
Section 1. The global burn epidemic.
To really grasp this, we have to ask ourselves, how do the rapid-fire decisions made in these chaotic initial moments actually dictate a patient's chances of survival? You see, a burn isn't just a skin injury, not even close. It's a massive, system-wide trauma that triggers a whole cascade of extreme physiological responses inside the body. What responders do in the first few hours directly determines not just if a patient lives, but what their long-term quality of life is going to look like.
11 million. Take a second to let that number sink in. That is the World Health Organization's estimate of worldwide burn injuries requiring medical attention in a single year. It just highlights the massive global scope of this crisis. We're talking about an estimated 300,000 people dying worldwide annually from fires and burns, with the vast majority of those happening in low- and middle-income countries. It is an absolutely monumental public health issue. And here's the thing that really brings it all into perspective. 73% of these injuries happen right in the home. This is a crisis that can literally affect anyone. According to the American Burn Association, flame injuries are the cause in 41% of cases where the cause is known. It's an everyday risk, and that's exactly why it requires such a highly coordinated, expert medical response. Moving on to Section 2, Primary Survey, the ABCDE.
Right, so before even touching the patient, responders have to practice body substance isolation. Why? Because burn patients have highly compromised skin, putting them at an extreme risk for infection. The skin is our primary barrier against the outside world. Once it's gone, the patient is incredibly vulnerable. So responders have to protect the patient from potential contamination while at the same time protecting themselves from bodily fluids or hazardous chemicals.
This brings us to the crucial ABCDE checklist. This rapid-fire sequence forces responders to stabilize the airway and breathing before they get distracted by the severe burn wounds themselves. And trust me, a dramatic, visual burn can easily pull focus. But if the patient's airway is compromised by swelling or smoke inhalation, they won't survive long enough for the skin burn to even matter. So first responders check for airway issues with spine protection, assess breathing, check cardiac status and circulation, evaluate neurologic disability, and finally expose the patient entirely to stop the burning process.
Now notice the stark contrast here when it comes to cooling the burn. While small burns get brief cool water, large burns require dry blankets to prevent systemic, potentially fatal hypothermia. Never use ice or prolonged cold water on a large burn. Never. Because the patient's skin is so severely damaged, their body completely loses the ability to regulate its own temperature. If you try to cool a massive burn, you drop their core body temperature, leading to hypothermia that restricts blood flow and can actually cause the burn to become much, much deeper. Warm and dry is the absolute rule for large burns.
Section 3, Secondary Survey and History.
Once the immediate chaos is managed, the team pivots into an investigation phase using the AMPLE mnemonic. Think of AMPLE as a vital mental anchor that guarantees responders gather the exact medical history needed before a patient's condition worsens. A patient might be wide awake right now, but severe swelling could mean they need to be put on a ventilator minutes later. Before they lose the ability to speak, the team absolutely must know allergies, current medications, previous illnesses or pregnancy, last meal, and the exact events or environment related to the injury.
Section 4. Sizing up the burn.
Here's a crucial detail to remember. When we're sizing up a burn for treatment, superficial first-degree injuries simply do not go into the math. Think of a first-degree burn like your typical summer sunburn. Yeah, it hurts, but it doesn't cause the massive systemic fluid shifts that second- and third-degree burns do. So, when we're calculating the total body surface area, or TBSA, only the deeper, partial, and full-thickness burns actually count. So how do they calculate that? They use the rule of nines, which maps the body out in roughly 9% zones. But it's fascinating because a child's proportions drastically change the calculation compared to an adult. For an adult, an entire arm is 9%, the chest is 18%, the back is 18%, and each full leg is 18%.
But for an infant, their head is proportionally much larger, so it makes up a bigger chunk of their total body surface area, while their legs count for less. Getting this precision right is absolutely key for what comes next.
But what about scattered, irregular burns? For those, responders use the patient's own hand size, including their fingers, to quickly estimate 1% of their body's surface area. It's known as the Palmar method, and it's a remarkably simple but highly effective tool. If a patient has a splash burn scattered all over their chest and stomach, you just visually map how many of their hands would cover those splotches.
Section 5. The Math of Survival.
Now we take those visual surface area percentages and literally plug them into the math of survival. These are the precise fluid formulas used to replace massive internal fluid loss, specifically tailored by age and injury type. Medical teams use a fluid called lactated ringers, calculating the dose based on the patient's weight in kilograms multiplied by the percentage of their body burned. For adults, it's 2 milliliters. But notice that children require more, 3 milliliters plus maintenance fluid. And electrical injuries require even more at 4 milliliters because those often cause massive, hidden muscle damage under the skin that desperately needs to be flushed out.
But we have to keep in mind, that formula, it is merely a starting point. The medical team has to constantly adjust the fluid flow based on how the patient's body actually responds. And the absolute best way to know if a patient's organs are getting enough blood and oxygen is by measuring their urine output. Hour by hour, the medical team tracks this output, dialing the IV fluids up or down. Too little fluid means organ failure, but too much fluid causes extreme, dangerous swelling. It's a tightrope walk.
Throughout all this complex math, we absolutely cannot forget the human element. We must aggressively manage the patient's severe pain and anxiety with IV medications while constantly monitoring their organ function. Burn injuries are agonizing. Providing strong opioids like morphine is critical, but it has to be given intravenously. A burn patient's body just won't absorb medication properly through the skin or muscle tissue. Plus, responders elevate burned limbs to bring down swelling and place a gastric tube to prevent severe nausea and vomiting.
And finally, Section 6, When to Transfer. This is the climax of the early emergency response, knowing when a local hospital is no longer equipped to save the patient. The American Burn Association provides strict criteria to instantly identify which high-stakes injuries mandate a transfer to a specialized burn center. It's not just about the size of the burn either. If a burn crosses a major joint, affects the face, hands, feet, or genitalia, or involves smoke inhalation or high-voltage electricity, the complexity skyrockets. These patients require a massive team of specialized surgeons, nurses, and rehab therapists that you can only find at a dedicated burn center. The quality of care during the first hours after a burn injury has a major impact on long-term outcome. That quote perfectly summarizes why we focus so intensely on these protocols. Every single drop of fluid, every single airway assessment, it fundamentally alters the patient's future. The initial management either sets the patient up for successful rehabilitation or triggers a devastating cascade of irreversible complications.
As we wrap up this explainer, I really want you to think about how these rapid-fire protocols in the golden hours dictate not just survival, but the lifelong physical and emotional recovery of the patient. The ABLS guidelines we explored today, they aren't just a list of emergency tasks. They are the bridge that allows a victim of horrific trauma to cross over into becoming a survivor. So next time you think about emergency response, ask yourself, how many thousands of calculations and split-second decisions would it take to save a life when the stakes are absolute?